Tonight, we are honored to have Professor Richard Harvey, who has traveled all the way from Australia to deliver a talk to us. Before he begins, let me introduce Professor Harvey. I think some of the friends actually knows Professor Harvey very well, but I would like to take the chance to introduce to him. Professor Richard Harvey is currently the professor and program head of rhinology and scalp-based surgery at the University of New South Wales, as well as a professor at Macquarie University. He is also a dedicated rhinologist specializing in allergy and endoscopic sinus and scalp-based surgery at Macquarie University and St. Vincent's Hospitals in Sydney. Over the years, Professor Harvey has a prolific career as a clinician researcher, both nationally and internationally. He has authored over 300 highly cited papers, books, and book chapters. He has been the recipient of the Distinguished Contribution Medal from the Australian Society of Otolaryngology and Surgery and the ESR Hills Award from the Royal Australian College of Surgeons. In recognition of his outstanding contribution to the profession in Australia. With all these achievements, he is recognized as one of the top 10 ENT researchers in Australia and one of the top 100 researchers in the world. Tonight, Professor Harvey is going to highlight us with his experience on how antigen immunotherapy is integrated with ENT surgery in the management of allergic patients. Without any further ado, I would like to welcome Professor Harvey to deliver his speech. Thank you.
Thanks, Martin. That's a very kind introduction. I said to Martin, you should just introduce me as a guy who's into nose and sinuses, because I think this summarizes my interest very well. And tonight I'm going to talk to you about really what I think is very important, and that's really how we manage allergy and rhinitis. It wasn't taught to me as a resident or trainee very well. Yet I think in practice, at any level in general ENT, it's one of the common things we see. Now, let me just make sure. There's my disclosures. I'm obviously speaking for Abbott tonight, but really I think what I'm going to talk about is more philosophy rather than any specific brand. But here's some unexpected concepts for you. So when I talk about rhinitis, I really don't use pharmacotherapy. So when people come and see me who have persistent allergic rhinitis, I don't talk to them about using medicine simply to suppress the allergic response, because most of these patients are in a many years to decades long condition. And if you really don't talk to a patient about a long-term strategy of sorting out their disease, they very quickly lose interest. And unless your short-term treatment is 100% effective, they're often non-compliant. I don't let patients make their own diagnosis. I very importantly don't let them decide that they've got sinus disease when they really have allergy. I really try to educate them about what's going on. And I also don't let the patients understand whether the allergy treatment is working or not. And I tell you why, because many of our patients, the only thing they judge whether their treatment is working on is whether their nasal blockage is resolved or not. If that doesn't come good in their minds, it's not working. And it's really important to separate that out. And we're going to talk about that. It's so much so that in my practice, and I was saying this to someone else, that if patients who have a very highly allergic airways, if they're not prepared to really engage the allergic side, then I really don't offer them surgery. And the reason for that is that, and I'll show tonight, that actually the benefit of surgery in highly allergic people is very short-lived. Many of these patients return to symptom burden that's very high. And you know what? A year after your surgery or 2 years after your surgery, if you don't engage the allergy, they're not going to say, oh, hi, I had surgery with Richard. it's not so good anymore because I didn't treat my allergy. They're going to say, Richard's surgery didn't work, didn't do anything for me long term. But the opposite is true. If you engage patients and you get them to treat their allergy as part of the overall journey, when they hit 2 years out and it's a life-changing event, they will say, I had surgery with Professor Hub, it was amazing. But they forget to tell, oh yes, and I had 2 years on allergy treatment. So it's actually a really important thing, especially for those who are in private practice. And that's very true. It's my last one here, is I don't let patients go for more than 6 or 12 months on any treatment strategy without it being absolutely life-changing. And this is very, very important. And you're not going to get that by tweaking nasal sprays and playing around with the number of times you give antihistamines a day. Now, why the big interest in oral immunotherapy? Well, we've had allergy treatments for a long, long time. Injections been around for some time. Sublingual or aqueous immunotherapy went through a phase, but it was highly heterogeneously practiced. A lot of aqueous solutions weren't a consistent concentration and extract. Some people even made up their drops in the back office before giving them to the patients. So the preparation of oral treatments was highly variable, and that actually gave aqueous or oral immunotherapy done by drops a little bit of a bad name. It's more not until recent years that there's been standardization. But standardization is absolutely of preparation of allergy treatment, very much in the oral tablets. This is one of their biggest advantages, is they are consistent, stable, high concentration of allergen. And they've really only been around since the late 2000s. And so in allergic asthma and allergic rhinitis, this is why we now have these oral tablets available. And look, we're obviously talking tonight about one product, which is probably the most applicable, and that's dust mite. But there are grass allergy tablets. There's a cat allergy tablet out there. So there is a range now of allergen-specific tablets that are on the market. Now, before we talk about this, though, because I said to you, I want to talk about philosophy as much as it is about how to treat people. The first one is that, do we interpret symptoms correctly? Now, there's a couple of studies I want to show you. I'm going to show two of these plots. This is a plot of when patients, we use the term nasal congestion, what do doctors think that means versus patients? So the doctors are in orange and the patients are in the blue or black here. Now, there are areas where nasal congestion, where patients and doctors are talking about the same thing. Stuffy nose, blocked nose, I think we all get that. But when patients use the term congestion, and like I said, this is actually not an English-only thing. When I travel through the Middle East and other parts of Southeast Asia, I know that it exists in Thai. I know it exists in Mandarin. When patients often use similar terms to describe congestion, they're not talking about nasal blockage. They're often talking about pressure symptoms. So these are people who have heaviness in the head, facial pressure, clogged ears even. And then there's even mucus symptoms, we call it. So this is the idea of having runny nose, mucus, just throat clearing. Even in English, that's what some people are referring to when they're talking about congestion. So this is a fascinating thing. So when some people come and see you and they say, oh, I'm congested, I'm blocked, they may not actually be talking about blockage of airflow, but pressure and heaviness. Now, why is this a problem? Because it's how we breathe. Our sensation of breathing is through a whole lot of nerves. And when airflow goes through the nose, it cools the surface. This is very important. So when we're going to talk about surgery for rhinitis, you do not have mechanical airflow receptors in your nose, not like when you touch a skin and there's tactile sensation. And there especially is not a set of little airflow meters in your posterior choana where the surgeon's goal is to create a tunnel to the back and somehow that will relieve blockage. That's not how we perceive breathing. We perceive breathing because air flows over the lining, and in particularly the front half of the nose. If you could probably say from the middle turbinate head-ish going forward is where you get this sensation. And as air flows through the nose, it evaporates the lining, the liquid layer, and you get a cooling effect. And this is why when you breathe in, it's a better sense of clarity of breathing than when you breathe out, because you're getting a greater temperature gradient when you do it. Now, this is important to understand when it comes to the application of surgery, because if you are a surgeon whose goal is to create a tunnel to the back of the nose, there will be lots of patients that you operate on who still feel a sense of congestion. And this also explains this phenomenon. So I think this is very common in rhinology or in ENT. Someone's had an endonasal septoplasty. Yes, they've just got a caudal high deviation. And we all acknowledge that these patients will say to you, I'm totally blocked on my left-hand side, completely blocked. And it's almost like an exaggerated symptom compared to what you look at. And you say, well, actually, there's a lot of space down below. And often the surgeon can see the posterior cornea. He's like, what's this patient complaining about terrible blockage? But actually what's happening here is they symptomatically are very blocked. And the reason is because that high septal deflection shunts air down the bottom part of the nose, and the entire upper part of the left nasal cavity doesn't get cooled. And because it doesn't get cooled, the patients don't get the temperature change and they don't feel like they're blocked. And I do a lot of external nasal work, all facial plastic surgeons, all you have to do is straighten the septum, restore this cleft here, and the patient suddenly feels like they can breathe again. That's really important because I can tell you the rhinominometry on these two people is exactly the same airway, but how the airflow through the nose is very important. And the other one too is understanding allergy when you see it. So I was told, now all my videos that I show you are post decongestion. I think this is very important. I was talking to someone else about looking in the nose without decongesting it. It's highly variable. The amount of vasodilatation can depend on what the patient has been doing, whether they ran late and rushed to your appointment, whether it's hot outside, what they've been eating. It's very important, I think, to decongest the nose to get a feel for what we're looking at. And I was told as a trainee that you can't really see an allergic nose. There's no real signs. I think in the era of high definition endoscopy, that is so false. A normal lining like this, where the lining is smooth and pale, there's space between everything, that's a normal nose. And an allergic nose is really obvious. It's cobblestoned, there's sticky secretions, there's edema here. When I look at this, I'm sure if I was a resident myself, I would have said, oh, there's a bit of a septal deviation. Do you know what? As a professor, that's not what I see. I see a highly allergic nose. The tiny mid-septal deflection to me is nothing. The highly allergic nature, the jelly edema here is really significant. And that's probably one of the biggest signs. So edema or polypoid degeneration of the middle turbinate head is really recognized as one of the strongest signs for inhalant allergy. Here's some examples of it. And we published this nice little review article just looking at, it's not just our group, there's quite a few groups that have published on what are the endoscopic features of inhalant allergy. And here's a normal nose for comparison. So classic changes are polypoid or diffuse edema. The diffuse edema is sometimes called the middle contact point, middle turbinate contact, because when you look at the middle turbinate, it's just diffusely edematous such that you lose the middle meatus. It sort of looks like everything touches. Other features are sticky secretions. And a really important one is when there's inferior turbinate hypertrophy, you lose this lovely armpit and you get this little bum cheek sign here, armpit sign. So the inferior meatus armpit appears. And these are really sensitive findings. So if you look at the diagnostic accuracy, this is an ROC curve where the top left corner is 100% sensitive and 100% specific. And if you look at the individual testing, the blue line, the middle turbinate changes are the most diagnostically accurate for allergy. So when you look in a nose, if you see middle turbinate changes, this is the strongest marker for allergy. If you said to me why, let me show you why this is the case. Here's my Indian patient who loves heavy foundation. So she loves putting heavy foundation on, and you can see it in her nose. It deposits on her septum, on her middle turbinate. But on even the side of her septal deflection, where yes, there's still foundation powder there, even on the side of the septal deflection, the foundation deposits on the middle turbinate head. And the reason for this, we think, is that as air flows through the nose, aerosolized particles lose their velocity and they drop out of airflow at around this point. And this is why we see an allergic reaction there. And it's far more accurate than this. So although we love to talk about allergen skin testing, epicutaneous testing, looking for a wheal, and when it is positive, it's a great sign. But actually, when it's negative, it's not a very good negative predictive value. And this has been looked at. So this is a Nisa Hamazan study where she looked at, okay, let's take people who are what we call a non-allergic rhinitis subgroup, what are the studies that have been done to look at nasal provocation test? If you don't know what a nasal provocation test is, where you squirt an allergen into the nose and you look for the reaction on rhinominometry and airflow testing. So it's sort of testing for local allergy where there's no evidence on blood or serum. There's quite a few studies that have been done. So this is a forest plot of all the studies that have been done on skin test and blood test negative rhinitis patients, on how many of them actually still have allergy, but it's just not on their skin or blood. And it's actually very high. So like almost 30% of patients who have a negative blood and skin test are still allergic, but they just don't have the surrogate test to show for it. So this is very important because I think some trainees are taught, oh, if the skin and blood test negative, then it's not allergy, it's non-allergic rhinitis, it's something else. That's not true. If someone sounds like allergic rhinitis, endoscopically they look at, just because their blood or skin test doesn't line up, that does not mean they don't have allergies. It just means you can't prove it on another thing. The other thing that's very important is age. So just being a child presenting to ENT means it's likely you have allergy. So this is a nice little Italian study that showed that most people attending ENT clinics as kids have allergy. It sort of goes with the nasal blockage, nasal symptoms, ear symptoms, eustachian tubes that we see as part of childhood. And this is one of our little studies, just looking at age as a predictor. So we took something like 500 patients complaining of chronic nose and sinus symptoms, and we said, what are the factors that allow you to say, just them, forget the endoscopy, the CT scan, and the actual assessment of the patient. What factors predict whether the final diagnosis is some sort of rhinitis or sinus disease? And actually, when you look at it, age was the main thing that predicted whether someone was more likely to have one condition over the other. This is the ROC curve. It's a pretty good ROC curve. Heads close to the 1. But you know what? One of the reviewers, when we published, he said to us, and it was a good statement, he said, look, I don't understand. How do you put this into practice then? Like, I understand age. I said, okay, no problems. What we'll do is we'll do you the diagnostic tests. So this is how the table looked. This is straight from the publication. We said, do you know what? If you see a patient walks through the door and they're less than 30 years of age, have been complaining of chronic nose and sinus complaints, their diagnostics odds ratio is almost 9 times more likely that they just simply have rhinitis than sinus disease. And this is in a clinic where all of these patients eventually went on and had a rhinologist look at them, an endoscopy, a CT scan, everything to tease it all out. But just age alone could tell you this. So when patients come and see you and they're 28 or 32 and they say, oh, I've had sinus my whole life, you know, I've got terrible problems, they've got allergy. That's essentially got a rhinitis reaction. And I don't let the patients dictate the diagnosis. And I do try to educate them. So here's the reason why. Here's another one of these studies by Ed McCool where they look at the difference between what patients are saying and what the clinician's saying. This is sinusitis. And we're all to blame here, right? In non-medical worlds, industry, pharmacy, other non-media groups, they use the term sinus to describe everything, right? From hay fever through to viral events, everything. It's a bit of a terribly mixed term. And there's some areas where you'd think they'd be consistent. So blocked pressure in face, blocked nose, pressure in face is what clinicians and patients think of this means sinus. We also think it means pain in the face. That's pretty consistent. But here's something else. Look, we find here in the clinicians, you know, and it's very different. The patients think it means phlegm, cold, tonsil, sore throat, and sneezing is what sinus is. And likewise here, clinicians more think it should be things like swelling in face, fever, and headache, but that's not what patients think. So it's quite amazing when patients come in and say, I've got sinus, and I'm sure it's the same in different languages. They actually, what they likely have is a rhinitis reaction. And much of that's got to do with the fact that they've seen green mucus. Green mucus is merely just myeloperoxidase. It's the iron-containing heme groups that create the green pigment. It's part of any accumulation. It can occur without a bacterial infection. Even just a viral event, there's a 100-fold increase in these, you know, neutrophils in our mucus and makes it go green. So just having green mucus doesn't mean you've got an infection. It just means you have an inflammatory process. And the other thing, I'm sure in Hong Kong it's the same, but it seems like in Australia, if you have a sinus scan, every scan is called sinusitis. There's no such thing as a normal scan. Even the most normal scans they still find something to say. There's a bit of mild something, right? And this is really important because if you're really an honest practitioner, if you're operating on scans like this for sinus disease, because the report says chronic sinus changes, you're not going to make patients better, and so it's really important that we have to be able to see what's going in the nose. You have to look at your own scans and understand that these are completely normal scans. So I never trust the radiology reports. But what I do a lot of is I do objective testing, because I've just explained to you that there is a huge disconnect between what patients say and what they're talking about and what the doctors think they're talking about. There's a huge disconnect when we see then in the nose what we suspect is happening with allergy. The age of the patient tells us maybe that this is just a rhinitis reaction. And when they say that I'm all blocked and I'm congested, I do objective testing. And probably the two most common objective tests are a peak flow and a rhinominometry. But I'm going to talk to you about rhinominometry because this is what I use. Every patient who comes and sees me has this. And anyone who's visited me in Sydney knows how I use this in the practice of my patients and workup. But the way rhinominometry works is that you have a pressure and flow curve. It's flow versus pressure. So if it's nice and vertical, you're getting lots of flow for low pressure. So that's an open nose. And if it's flat, you're getting low flow for high pressure. So it should look, doesn't take long. That's how long it takes to record. It looks like this when it's normal. You can pick up changes like nasal valve dysfunction. So when you have nasal valve dysfunction, you get sort of weird looping on one side because as the person breathes in and out, their side wall sucks in. Now, I know in an Asian crowd, that's not such a big deal, but in Caucasian noses, this is something that does plague people. They get blockage, especially as they get older. But you can especially see a blocked nose because when it's congested and blocked and it's physically obstructed, it looks flat like this. And this is a boy in which I'm going to show what's going on. Now, the reason it gets blocked is a mix of things. Now, for some people who have a very congested nose, and I use the word congested meaning that they don't have terrible hypertrophy or tissue remodeling. Does everyone know this difference? When I say congested, it means there's a lot of vascular dilatation, a little bit of tissue remodeling, but mostly vascular dilatation. You'll see them, they'll come in like this, and with treatment, they'll come good. And some minor changes in the nose will get better with stuff like allergy treatment or even just why they're on a nasal spray. But there's a lot of patients who start like this, and despite going through treatment where the treatment's working, the patient said to you, I'm not itchy and sneezing anymore, my eye symptoms have gone, but they come back with an airway like this 6 months in, they will say to you, but it's not working, my treatment. And the reason they say that is not because it's not working, it's just that they're still blocked. And this is the time we as surgeons have an enormous advantage over respiratory doctors, immunologists, allergists, because we understand in the nose things happen, such as this. Patients get terrible tissue remodeling. This is not congestion. This is thickening and tissue remodeling compared to a normal nose. And I think most people can see it. So I think most ENT surgeons, when they have this patient present to them, they intuitively know that this person's going to need a turbinate reduction at some stage. But the problem here is that the turbinate surgery doesn't remove the cause. The cause here is allergy. And so, yes, while we do turbinate surgery and we apply surgery to create more space, I'm very realistic in the fact that all surgery does is it's very unidimensional. It just creates space. This is very important because the people you need it on are people like this, whose allergy treatment is progressing well, but they still feel blocked. If you do surgery for him, his nose will open up and he'll feel better. And I'll show you his case as a case in example. Now, why do it? Here's Enrico de Corso's study. He looked at rhinitis patients having turbinate procedures. What happened to their symptom burden over time? And Enrico's very honest. He followed up the non-allergic patients and showed that, yes, they do deteriorate over time, but actually allergy patients deteriorate terribly over time. And especially if they're not really engaged in allergy treatment or just told to, you'll go back to using some antihistamines and a spray, by 5 years, 80% of them are back to their symptom burden. And really unmanaged allergy really can impair the surgical outcomes for people. And this is a really important part of understanding. So where do I place allergy treatment? So first of all, the benefit you get from allergy treatment is at around the 3 months to 12-month zone. So you get this huge inflection here where, you expect to get a massive benefit, but it does plateau off here at about 12 months. So you should never leave a patient on for more than 12 months without making sure that their symptoms really have resolved. And if something hasn't resolved, like blockage, you need to be in there quick and smart and do things like turbinate surgery, because otherwise patients are going to feel like their progress is stagnated. Surgery, on the other hand, is the opposite. Surgery will give you this massive benefit early on, and people go through, what I call a honeymoon phase. So early on after surgery, and everyone's familiar with this, the trauma of surgery suppresses the allergic drive for a period of time, and they almost feel like they're sort of cured. And then, of course, given enough time, as long as there's still active allergy, it'll all return. And so you don't want to start allergy treatment back here. So the time to start allergy treatment, in my opinion, is what I do is I end up starting people on AIT. I really like to get that going first, because then I have a chance to sort of see that the patient's engaged, they're willing to do it. But their very next appointment is one to see whether or not their nasal blockage is resolved. And that's really important, because the very next appointment is, do we need to do a septal or turbinate surgery? And that allows me then to very quickly talk to them about doing it. If you try to engage patients in allergy treatment in the 6 to 12 months after your surgery, you are wasting your time, because they don't feel like they have terrible allergy at that stage. And often they won't engage in it. And then you end up having to let them fail before they then actually feel motivated to do it. So this is really important. And turbinate surgery does enhance AIT. This is a study we did where we looked at patients who were on AIT versus AIT and had a turbinate reduction. And our primary outcomes here were patient-reported obstruction and airflow studies through peak flow and rhinominometry. And what we could show here is that patients who had AIT and inferior turbinate surgery had both greater symptom improvement as well as better airflows. Now, that may seem obvious, but actually there are some people who feel so strongly one way or the other. It's actually the combination of the two is what actually brings around synergistically the best effect. But someone once said to me, Richard, he goes, I think this is Ray Sachs. He said, Richard, you'll find that turbinate reduction patients are our most grateful patients and our least grateful patients. And the reason for this is for the reasons I've discussed. One is that you can't cut the allergy out of the nose. So if you have a highly allergic patient and you simply just operate, they'll often have their symptoms return very quickly. And in some young kids, I can see them within 6 months of having care elsewhere, and they've already got a completely congested nose again. And the other one too is that, and that's worse, is if you get the congestion story wrong and what the patient's talking about is heaviness and pressure, by doing septal and turbinate surgery, you're not going to help that patient. They're going to think that that surgery was very low yield. And then all you have to do is operate on a patient who has heaviness and pressure and thinks their nasal congestion is causing their lack of sleep and their lethargy and malaise, and hoping that their life is going to improve dramatically after your surgery. And there you've got your empty nose patient waiting to happen. So how do you tell it though? You might say, Richard, but you've got rhinominometry to tell you who's blocked and who's not. How do I do it if I don't have rhinominometry? Well, you can look for symptoms of turbinate pathophysiology, and I use a thing called Ray's rules. If patients still complain of a lot of nasal cycling, so they can feel one side opening and the other side closing, this is a great sign of turbinate pathophysiology. If they get a blocked nose when they lie flat, so the orthostatic pressure, venous pressure that comes with lying flat, blocks their nose up, this is probably they've got turbinate hypertrophy. And if they love decongestant sprays, this is one here. But you know what? If someone doesn't have any of this, then I'm really cautious about, is really a septal and turbinate surgery the right thing for this person? I'd be very cautious. And all too often, I would say the rhinominometry in these patients is often very, very normal. And so they're the patients I don't operate on. So let's go through a couple of case stories. So this one I showed you a photo of. He's a 13-year-old boy. For the last few years, he's just been very congested in the mornings. He's perennially like this all the time. He doesn't have bad asthma or dermatitis. He's got a lot of other reactive symptoms, itchiness, sneezy, wateriness. He saw his GP or primary care doctor, was told to use a nasal spray. He can say, look, when I'm taking it, I feel a bit better. But like many pharmacotherapy options for allergy, they're not 100% effective. And actually, if you look at data from pharmaceutical sales. 80% of patients poly-treat themselves. They buy multiple things down at the chemist or pharmacy to treat their allergy. They're not just taking one spray or one antihistamine and that does the job. And here's his allergy testing. He is a little bit polysensitized, but most to dust. And his story is with the dust because he has perennial congestion and worse in the morning. This is very classic for people who have dust mite allergy. And his airway looks like this. And I showed you what happened. I put him on allergy treatment. He did come back and say to me, Richard, after allergy treatment, his airway was like this. Now, to me, it's demonstrably better after 6 months. And when I asked him, I said, you know, have you got itchy eyes? Did you react to the tablet? He's like, yes, I react to the tablet. My itchy eyes have gone, but it's not working. And why is it not working? Because I'm still blocked. And if you nut it out, that's why he thinks. And the problem here is that if these patients see allergists or respiratory doctors or immunologists are dumbfounded. They don't understand that what's going on inside is that this person has turbinate hypertrophy and congestion. And so here we are now. Here he is after allergy treatment. I look in his nose, and yes, he's got this. It looks a little bit tight. This is all post-decongestion. This side's not terrible. Look on the other side. This side's a bit more, got turbinate hypertrophy. It's got a bit of big swell body up there. This actually is not a septal deviation because I'll show you his post-op. Here's his post-op now. Turbinate reduction's been done. The middle turbinate's been reshaped and the septal swell body's been removed. On this side, he hasn't had septal surgery. Turbinate's been done. The septal swell body's been treated. He didn't have septal deviation. He just had septal swell body. And we'll talk about this more. But post-surgery, his airway opens up. And you can see the difference in the airway. We've gone from this to this and from that to that. And in the process, he now thinks that he's got this amazing cure. He's only 9 months after initiating the whole treatment. All his reactive symptoms are gone and all his obstructive symptoms are gone. Now, at the time of surgery, I always do blood tests for a couple of reasons. One, it tells me how allergic they are. So you can see his IgE is over 1,000 or 2,000. And the dust mite, just like his clinical story was really the main allergen here. Not only did he clinically have dust mite allergies, even though his skin test was a little bit polysensitized, you can see from his blood test that really the dust is the main thing that's driving it. Now, you should see a benefit in the first little while on treatment. So if you look at chamber studies on people undergoing AIT, this is a dust mite challenge test. You know, at baseline, as early as 8 weeks, you'll see about 20 people get symptom benefit. They lose their responsiveness to dust mite in a chamber study. And then by 24 weeks, there's a significant drop in symptom burden. So this is when you should see it. It doesn't take a long time. You should be able to see a benefit from immunotherapy early. And here's a slide this is a Bergman study. It's actually with another dust mite product, but it's a nice study because it shows that even after 1 year on treatment, the year after that 12 months of treatment, there's still a retained benefit having been on dust mite treatment. And so you can see that even if you get people through 12 months of treatment, they maintain a degree of allergy tolerance. Now, one thing I touched on in my talk was that I don't focus on simply just doing septum and turbinate surgery. When people come and see me and they've got a congested nose, their rhinominometry is high, their resistance is high, I see myself as a nasal airway surgeon. I want to restore evaporative cooling and air conditioning to the nose. So when I look at this nose, that's a normal nose. I look at that. Now, I don't think I appreciated the middle turbinate edema as I should have when I was a resident, but I look at that and see it. But I look and I see this photo. I say, yes, he's got allergy, but look at the swell body. Look how the swell body is relatively thin here and thick here. And the swell body should not be thick. The swell bodies for most people on normal scan should look like this. But the swell body has been shown to increase in size in allergic diseases. It also correlates with inferior turbinate volume. So people have done some nice studies to look at it. You know, it's often greater on the other side, and it's full of this vascular glandular tissue. It is a very distinct structure and is often referred to as the septal turbinate. That's often its name. Now, I point this out because everyone here is probably very capable of doing septal and turbinate surgery, but a very common phenomenon I see in practice is that, apart from not getting on top of the allergy, is that people do an amazing septoturbinate surgery, and then they leave behind in the upper part of the nose this incredibly congested congested nose. We're almost the septal swell body, the middle turbinate lateral wall, are almost like a sandwich together. And the patients will say to you, I've breathed better, but I still feel stuffy up here. And while I was talking about this, and one of my members in the audience at a course said he was an immunologist, and he came up and saw me and said, Richard, I think I've got this. I've had 2 septum and turbinate surgeries, and I have this terrible sense of congestion in my nose. First of all, he was grass allergic and still not treating his allergy. But when you look, this is his right side of his nose, decongested. And have a look here. Look how awful and tight it is. That's not a septal deviation. That's entirely a huge septal swell body. Here's the other side. You know, the other side's just as bad. It's just as spongy. And of course, we do a surgery, we trim all that away, and here's what it looks like, you know, 5 or 6 weeks later. You have to cover it with silicone when you do things like that, because I simply just shave it down. I don't have anything fancy I do. This side was easy. Here's the side that was terrible. And he's probably one of the biggest swell bodies I've had to reduce. And you can see it's taken a little bit of time to recover, but you can actually see it's mostly healed now at 6 weeks. But it's a huge difference. And he absolutely said to me, apart from I made him start allergy treatment, if it's an allergist, he just said straight away, I can feel an enormous difference. Let's talk about another case, because I showed you a boy there that went from a terrible chronic allergy state to asymptomatic on AIT in 9 months. And that's how you get there. You don't get there by giving them 12 months of sprays, use antihistamines, see you again, talk about doing a combination spray, see you again. The reality is that even if you did get amazing symptom relief, suppressing the allergy with pharmacotherapy, I would ask as a parent, where's it all going? Do you know when this is magically going to resolve? Well, actually, for most people, it's a years to decade-long condition when they have perennial rhinitis. So here's another boy, just to show you that this is how I manage patients. So this boy's come and see me. He's a 15-year-old gentleman. He's got high airway resistance, itch, sneeze, conjunctival symptoms. He's like that all the time. My management is simply to start dust mite immunotherapy and see him in 3 to 6 months. And if you said to me, Richard, are you waiting to see him to make sure the allergy treatment's working? Not really. I'm really just making sure he's engaged as a 15-year-old, that he's willing to treat his allergy, because I know that unless he doesn't treat his allergy, I'm not going to get an amazing surgical result. And of course, his symptoms, he's got lots of nasal symptoms along with sleep issues. That's often very common. Here, if you have a look in his nose, he's got a sort of a classic allergic nose. You know, there's a fair amount of turbinate hypertrophy there. It's not absolutely terrible. Here it is here. And of course, he's got polysensitization, perhaps more than the last patient. He's got a congested nose, not as bad as a congested nose. And when you start this personal allergy treatment, his mum's a bit uptight. You have to talk to the kids and the parents about local reaction. When they put the tablet under their tongue, they should get some sort of itch, even a little bit of swelling where the tablet sits. That's a normal response. Actually, if you're not allergic, you shouldn't get anything. It should just feel like a piece of paper. It does to me. And actually, I almost like to have patients have some local reaction, because I tell the patients, it's very reinforcing that we've picked the right allergen to drive your immunotherapy. And of course, this boy has a very high IgE when he has his blood test. Now, he is a little polysensitized, more than my last patient. And I'm going to bring this up because he does have high serum eosinophils as well. I still leave him on dust mite immunotherapy. That's his airway test to begin with. Here he is post-surgery. I'd like you to have a look at his surgery. His airway looks exactly the same as the last boy, even though structurally they look like they might have been different. I haven't actually done any cartilage work here or bony work. I've just shaved down soft tissue. I've shaved down the turbinate, I've shaved the swell body, and I've even shaved a bit of the middle turbinate to recontour it. And then that's how I get the airway open. And it's about restoring airflow cooling in this area. And here's a little video, because I gave most of this talk already today. And someone said to me, I want to see, what do you mean by shaving turbinate? So here's someone who's got all three, right? They've already had septal turbinate surgery. You can see a previous septum, but look how edematous the middle turbinate is. So we inject local in all the areas we're going to shave down. Here it is what it looks at the end of the procedure. So I have pushed the turbinate laterally. I've shaved the edema off the middle turbinate, and I've taken the swell body off. You can see how different it is. It gives you then eventually an airway that looks like those examples I gave you. Now, why get patients on dust mite immunotherapy when they may be polysensitized? As long as they show perennial allergens, and you pick the most relevant protein. This is all you need to do to get a good response. And actually, in big studies on dust mite immunotherapy, and they show a benefit over 12 months. And in particularly, I think as surgeons, we often capture people for 12 months. They're in our sphere of influence for at least 12 months. They'll go along with what we have to say. But lots of these patients in these studies, 68% were polysensitized. And actually, the allergy camp around the world, there's really two thoughts. Most physicians, I say, do what's called monotherapy. We just want to pick the allergen that we think the patient is going to react to the most and use that to drive the immunotherapy. What we try not to do is look at a skin test, disregarding the patient's clinical history, and dump a whole lot of different proteins into an injection or a liquid and give it to them. If you do that, the polypharmacy approach or polyallergen approach, you often end up with a mixture of a whole lot of different allergens and not enough of any one allergen to bring about the immune response that you're trying to seek. So you don't get enough dose, enough highly concentrated dose to get the response. Now, here's a little tidbit for teenagers. This is not that guy, this is someone else. This is someone else who's been on allergy treatment. I thought it was working. He's had surgery, comes back and sees me. Mum's super disappointed. He's all congested and mucousy again. And I get blamed for the fact that it's not working. But the reality is that when you do a swab, he's just got rhinovirus. So it's really important to remember a lot of kids who go through rhinitis care, they're going to spend 3 or 4 times a year, have some sort of cold and virus. It's part of the deal in that world. So let me go through the last case. This one you'll all be familiar with. A guy who's 30, he tells you he's had sinus his whole life. He doesn't really have a lot of other allergic phenomena. He's tried everything. Only oxymetazoline works for him. And you look at his rhinominometry, you can barely get a reading. His nose looks like this. It's all super congested. But what he's got is he's got a fair amount of remodeling. He's got turbulent hypertrophy. So this is not someone who's just simply started a decongestion after a cold and simply just had problems getting off it and just a rebound phenomenon. This person clearly got to a point where he had such bad tissue remodeling that things got worse. Hey guys, we should make sure dinner comes out because I'm coming up to the end of our talk. I said I was very happy for dinner to come out. So please have the food come out if they're waiting. And when we do his testing, he's highly allergic to dust mite. And he's got this picture in his scan. And anyone who knows anything about allergy, this is what highly allergic person with edematous middle turbinates looks like. So it's not sinus disease, this is allergy. And so he goes on immunotherapy. And then we do septal and turbinate surgery. Once again, inferior turbinate's been done. You can actually see the scarring on the middle turbinate where I've remodeled the middle turbinate. This is the same guy's nose that you see here. Now, I didn't do a whole lot of sinus surgery because his problem's not sinus. It's this thickening of the center part of his nose from allergy. And I don't try to get these patients off oxymetazoline. Many of them have tried, they've been on it for a long time. And if they have terrible, terrible addiction to oxymetazoline and they have allergy that looks like that, we really do say to them, listen, let's use surgery to break your addiction to the oxymetazoline. And so they start allergy treatment. We published on 56 patients that were treated like this, where they'd been using oxymetazoline between 1 and 10 years. They'd already had everything done, allergy treatment. They had trialed coming off decongestions and serial dilutions and everything else. But we simply just took them through a process of having them use their oxymetazoline right up to the time of surgery. And then just a few days before surgery, they have them stop. They stay on allergy treatment. We do their surgery. And in the sort of 3.5 years follow-up, we're able to get 91% of these patients completely off decongestion sprays. A few percent still have it. And then, of course, there's a small group that you can't help at all. Now, this patient, I think, is very important because you might have looked at that scan and thought, oh, look, that looks like CCAD. But that's, of course, this other phenomenon that we see in allergy. So this is this idea that some people have such an exuberant allergic response that in their nose, they have a nose that looks like this on the left, where it's just jelly edema coming off the center structures of the nose. We call this central compartment atopic disease. It's very different You can see on the left how this person's got edema of their middle turbinate, but the patient on the right, who's never had a problem and then just in their 30s to 50s has developed asthma and polyps, they have a completely normal nose. And on the right-hand side, the polyps are really just coming out of the middle meatus. But on the left, the polyps are coming from the turbinate. And this is a real difference. So we really acknowledge that these allergic patients with this central thickening, they often have scans like this. Now, they buy themselves sinus surgery, and rightly so. Many of them get secondary sinus problems, barotrauma. But do you know what? This is one of my patients who's highly allergic, who I did sinus surgery, and he never followed through with allergy treatment. And this is what he looks like 7 years later. His sinus cavity is completely normal, yes? And he had barotrauma. His barotrauma was solved by his surgery, but not treating his allergy. You can bet I trimmed all of that back 7 years previously. His central part of his nose has just thickened up again. And I can tell you, he wasn't just symptomatic in the last couple of years. He was symptomatic from about 18 months again. So he went through the classic honeymoon phase of being asymptomatic for a while, thinking he doesn't need to stay on this allergy treatment that Professor Harvey told him. And this is what happens down the track. And we published a paper last year looking at people who were dust mite only positive, who had their sinus surgery with and without AIT, and showed that 12 months post-surgery, looking at new tissue remodeling and symptom and treatment scores, that people who were on AIT had much less significant polyp change or new changes on their turbinate and much less medication requirements for being on their AIT. So just to show you that AIT really can modify that disease process in those patients. So in conclusion, it's really important. You've got to get nasal congestion right. It's the dominant symptom. It's often what patients anchor their entire treatment response to. Objective findings such as endoscopy and rhinologist help you sort out patients who are merely talking about other things, heaviness, cloggedness, mucus. Skin testing has its limitations. It only aids in diagnosis and maybe selecting an allergen. And a really important thing for me is that although I start patients on immunotherapy very early, it's one of the first things I want to talk to patients about, because I say to them, look, this is what I'm going to be doing for you that's going to get rid of the underlying process. But I say to them, listen, but you may not unblock your nose. So you come and see me 3 to 6 months, we'll see where you're at. And I tell you what, if you're still really blocked, we'll go ahead with that turbinate and septal surgery. If they then do it with you over the next 3 months, and then what are you looking after them for 3 or 6 months after that? Even if you've got them engaged with allergy treatment, you're now up to like a 12-month period on immunotherapy. And we know from data that that's about when you start to see patients have prolonged built-in tolerance from having been on AIT. So here's a few QR codes for some of the papers I talked tonight, and thanks very much for listening. Happy to have some questions.
Thank you very much, Professor Harvey, for the wonderful presentation. I think there will be a lot of questions on the floor, and well, I promise you, we will have a very short Q&A section afterwards.
Yeah, sure.
So it's very beautiful to see you Q&A section. Is there any question from the audience? Yes.
Yeah.
Thank you very much. It was a very nice lecture. But you did mention about smell. What's the response to smell?
So smell loss should be incredibly uncommon in inhalant allergy. Most people do not lose their sense of smell. Even those patients with terrible central compartment atopic disease don't lose their smell until very, very late. And then when they do lose it, it's not like the smell loss we see in adult onset polyps and asthma, where it's profound and it comes back with steroid. They really have smell that's intact until very late. And then we think in the CCAD patients, their smell comes and goes, and we think it's really just a conductive issue. They just go get the odorants up into the smell cleft. But the smell cleft itself doesn't undergo these allergic changes. You don't see it in there. It's all happens in the center part of the nose.
There are patients that there's some vegetation
Yeah.
There's no major problem, but they have smells. If the ball is sterile, that.
Yep.
Is it the case of all?
I'm not sure. I'm not sure I agree with you there. I think I'd be very careful to know whether that's someone not with allergy, but with just mild eosinophilic airway disease. See, I think there's a lot more patients like that because in allergy, you really don't lose smell until very late. I mean, I can always think that you could find a couple of patients who have like a concha bullosa and then they've got edema, tissue remodeling, and maybe that does create a conductive problem. But if you've got a patient who simply takes 1 or 2 days of prednisone and all the smell comes back, they don't have allergy. They've got some sort of type 2 airway disease. That's not allergy in nature. That would be my feeling. And especially if you look up in the middle and the olfactory cleft ain't that bad, you know. Or they've got rhea or something else going on. Rhea is really common. Do you know, everyone knows what rhea is? Rhea is this glandular proliferation or hyperplasia that occurs, you know, just below the smell cleft on the septum, and that can create smell loss. But once again, it's a conductive smell loss. Yeah.
Question. If the exclusive complaint is itchiness, rhinorrhea, and obstruction, which is not the main complaint, are they candidates for AIT as well?
Yeah, 100%. If they're perennially like that. Now, I've got to be very careful here, right? Because I don't want to poo-poo or dismiss the role of nasal sprays and antihistamines. Like around the world, there are many, many places in Europe and North America where people get highly allergic for 2 or 3 months of the year, and they need to treat their allergy and suppress it. And for the rest of the year, they're fine. But when they have chronic symptoms, doesn't matter what it is, blockage, itchiness, sneeziness, these patients, I really just talk to them about immunotherapy. I'm only really interested. And I often will say, I apologize to the patient. I say, listen, I'm not going to talk to you about nasal sprays and antihistamines. I say, I'm only here to talk to you about a long-term strategy to get you right. That's all I'm interested in. And do you know what? 98% of patients will be super appreciative of that. And then I really think that if you just blanketly started everyone on AIT, there is a group of people that have a mix of blockage and itchiness and things who come back and say how well they are at 6 months, and they're just happy to keep going. And do you know what? That's totally fine. I say to them, let's do it for another 6 months. Come back and see me. Let's see where you're at. I often will follow their rhinominometry, and I really let them make a call. And I say to them, listen, if you get better and better and better, but if you reach a plateau, especially where it's blockage that's not getting better, then I say, don't stop your AIT because you think it's not working. I said, that's the time to come back and see me to talk about septal turbulent surgery. And that's a really important message. I've got something I want to throw just while we bring the mic over here. One thing I often get, you know, and I'm old enough now that I can say this, you know, always when I give a talk, some old guy will come up and say, oh, but Richard, I've cured people from polyps and I've cured people with my surgery. I know I have. This has happened, right? We do cure people from their symptoms with surgery, and I tell you why. It's what I call the union of probability. So what you have here is you have a patient who's got tissue remodeling and a surgeon, and this is usually in the setting of CCAD or persistent allergic rhinitis with tissue remodeling change. But what's happened here is that the patient has presented to the ENT surgeon at a time when the natural history of their condition has run its course. So they're 32, they were highly allergic as a teenager, but just not anymore. But their nose is left with all the tissue remodeling from years of allergy. And all they have to meet is a surgeon who enjoys turbulent and sinus. And when these two people meet together, they get a cure. And the surgeon, emboldened by his or her amazing outcome, then applies their surgery to the next 10 people in exactly the same way and doesn't get the same outcome and doesn't understand why. And that's because you've just been lucky as a surgeon to meet someone at a time in their life when the only thing really that's getting in their way of good nasal function was just all the tissue changes from years of previous allergy. Yeah, sorry.
That's again, great lecture. Two follow-up questions is the case study with the 14-year-old child with a hypersensitivity to one specific allergen. For cases that you mentioned earlier, some may not have actual positive tests, either in the serum or in the skin prick, or if you cannot identify the specific allergen, you mentioned that it's better to have a specific allergen immunotherapy rather than to load them with multiple allergens.
Yeah.
How would you proceed with the immunotherapy for those?
It's actually easier than you think. So years gone by, I had a nose lab where I used to do nasal provocation testing to sort of tease that out. The problem with nasal provocation testing is that you have to do like a saline control and then a saline with the dust mite. And it's really a slow, laborious thing. And I still do it occasionally for a pediatric immunologist who I think the parents really like to know for sure that their child's allergic. But actually, most people, if they sound like they're allergic, endoscopically they look allergic, and then their story is very giving. They just say, I'm like this all the time. I'm worse in the mornings. If I go into a dusty cupboard or I dig around, that sets me off. I just simply say, look, listen, the tests and bloods don't confirm it. So we're going to give you dust mite immunotherapy, and we'll just give you the oral tablets, and we'll do it over the next 3 to 6 months, and we'll see what response you get. Now, often when these patients then put the tablet under their tongue, they get a local reaction from it. And I say, yeah, that wouldn't be unexpected because, that's reinforces that we've picked the right allergen. And so sometimes you just have to proceed in the face of incomplete data, but you shouldn't be looking at a blood and skin test and then throwing out the animal that quacks, walks, has got web feet, loves the pond, and not call it a duck. Like it's a duck, you just don't have the test to show it. So sometimes you have to do that, and that's what I do in those patients.
You mentioned that usually takes up to a year for the durable effects.
But for a persistent effect. Yeah, that's about the earliest it comes. Yeah, so keep going.
So how long would you keep them on the medications, or after the 1 year, if they're really great response, do you stop them?
Yeah.
And when do you expect to restart them?
Yeah, it's a really good question. So this is a really common thing I get from patients. So first of all, when I start people on it, I absolutely say to them, you've got to get a response in the first 6 months. No one goes longer than 6 months on immunotherapy without there being clearly a benefit. And you have to tailor that comment with the idea of teasing out a patient who's just like, I'm still blocked, I'm not better. So I give 6 months for the benefit. I never stop allergy treatment earlier than 12 months. But from 12 months, and I say to most patients who are young that you're probably going to need to be on it between 12 and 36 months. And I'll stop it as early as 12 months if they meet these sort of criteria. This is my loose, because there is no test. The people are doing investigations to see if we can determine when the tolerance and the IgG4 and everything that's produced as part of it reaches a point where it's clinically relevant, but no one really knows. But my rule of thumbs is that they have to have lost their reaction to the tablet. So they have to, when they put it, they never react to it. They have to be essentially symptom-free. They then have to look in their nose, and in like, what are you now, 9 months after their surgery at the 1 year time point, I have to see no new allergic changes. So they're not allowed to have new turbulent head edema, that's happened in the 9 months after my surgery, assuming they started 3 months prior to surgery. And then if they're symptom-free, they meet all those criteria, I actually say to them, okay, you can stop as early as 12 months. And what they do is they stop, and I say, after 3 months, keep a week's worth of tablets in reserve. And I said, if after 3 months you notice symptoms are coming back, then we're going to put you back on immunotherapy. And if after 3 months I get you to re-challenge yourself with the dust mite tablet, if you react to the tablet again, then I say you need to do a bit more. But there will be a big group of people from as early as 12 months who will say to you, listen, I'm cured, especially young people. They'll say, okay, I'm totally fine. And then so this is how I tease it out. And you lose nothing from just having the patient engaged in that process. And then they always know that if they're not quite there. And you'll meet people who are like 70% there, but you know what? In their minds, they're cured. And just because now a 30% symptom burden, they're just not fussed at treating that. It's in their minds they're cured. Yeah. We got Michael. But that's a good question because there is no golden laboratory test.
So this is top and so I have two questions. So
Yeah.
I choose not to answer the first one.
Let's go for it.
The first one is we do have some experience with SLIG for some
Yeah.
years, and then we use serial dilution and maybe multiple. Usually, there's a single, as you said, dust mite allergy in Hong Kong. So what's the clinical difference between this single dose and the single dose and the use of those with serial dilution that we're titrating against the clinical response. Do you find any difference?
I'm not sure I completely understand. You mean because first of all, most sublingual regimes, are you talking about injections or aqueous oral? Yeah.
Serial dilution and we titrate against skin responses on serial dilution.
Yeah, I mean that's like Americans.
Those titrated.
Yeah, Americans who do modified quantitative testing, and that all occurs in North America. So just everyone is aware, people may not be aware in the audience, and correct me if I'm wrong if I explain it. So like in some parts of the world, really just in North America, nowhere else in the world, they do this thing where they do serial testing on the skin at different concentrations, and they work out what is the dose to start someone's treatment, and then they slowly up escalate the dose, in particularly for subcutaneous, but they do it in sublingual as well. My feeling on all of that is overplayed. No one really else in the world does that. Like sublingual treatments, even if they have a slight up escalation, it's very quick, often only a number of days to up escalate. And really oral immunotherapy tablets, most oral immunotherapy regimes, whether they be dust, cat, grasses, they have almost no escalation or minor, like over a few days. And I think even some of the tablets where it's like 3 days of escalating, it really, in our world, we don't think it makes a huge difference to their escalation phase symptoms. And it's a leftover, in my opinion, phenomenon from when people were at high risk of having anaphylaxis from injection immunotherapy. So I think that's where it comes from. And so my feeling is that there's a whole world outside of North America that doesn't do all that titration. Yeah.
But eventually decide to use single delta.
Yeah, but it was historically. I agree. It was there. But this is where I think so. So for me, I don't think any of that's required.
We have very limited experience with
No, they are the group. They are not. If you are treating someone in their 40s, you have missed the boat. Yeah, 100. The target group is kids. The target group. This is the time to offer immunomodulatory therapies. It's been shown to modify the allergic march for patients. It changes the progression of allergic burden of disease. So you're more likely to avert very significant other allergic comorbidities such as allergic asthma, allergic rhinitis, allergic skin changes by capturing people early. And you're more likely to avoid new allergen sensitizations by treating a person early on who's like highly monosensitized to dust mite or something like that. So my biggest effects, Michael, are in kids. So they seem to have an immune system that is very pliable still. And I will have these amazing results where even just a couple of months into treatment, the parents will call me and say, my child's a different person. But when I start someone who's 35 or 40, I prepare them for the opposite. I say to them, listen, you might need to be on the treatment for 12 to 36 months, but because we're coming in now in your 40s, you might need to expect to be on the higher end of that treatment period than the shorter end. This is my experience.
And the dose is the same.
Yeah, same dose. Same dose.
Where is that after age 5?
Yeah, no, allergy immunotherapy is World Health Organization recommendation is 5 years and up. I think at Carazax here in Hong Kong is 12 years and up. Correct me if I'm wrong, but I mean a lot of that's just got to do with what's been put forward in studies for the local regulator. But the World Health Organization suggests allergen immunotherapy from 5 years and up. And it's a practical thing, Michael, because before the age of 5, it's very hard to know whether someone's really allergic because they're still at age when they're attending daycare, they're getting lots of viral rhinitis. And so I think 5 is a practical thing that you can pick them up. And it's also about when they start to undergo the allergic march, where they start to have the combination. They often have the skin early, but then they get eyes, nose, and lungs. You can sort of tease them out.
And do you use perhaps allergy as an endpoint or somehow in the middle of the therapy you those on just
I don't use it at all. And actually the opposite is true. When you start people on allergy immunotherapy, their IgE can even rise in the early phases. in the first 6 months.
Purely on symptoms, but also be.
Yeah, rhinoscopy is undersold, Michael, I think, in our profession. People, like, because allergists don't know what they're looking at. Is there any allergists in the room? Sorry. but they don't know what they're looking at. Half of them, they think the turbinat's a polyp, right? They've got no idea, right? So let alone nuancing out things like middle turbinate edema. You know, that's why ENT profession is uniquely positioned to see what's really happening in the nose. So you pick the right person. We're uniquely positioned to get rid of nasal blockage, which is what holds a lot of people back from staying on their immunotherapy. Because when they go and see immunologists and say, oh, my immunotherapy is not working, immunologist doesn't know what's going on. He just thinks, oh, okay, then, you know, better go back to the nasal sprays. You know, so, and then, of course, we're uniquely positioned to see whether the allergic disease has really ceased, having been on there in a period of immunotherapy period. So, yeah.
Thank you, Richard. I've got two questions. For kids, how small would you do the shape their turbinates? Would you do it with that 6 years old?
Yeah, it's just rare that I ever see a 6-year-old who needs it. Because you have to have had allergy long enough, David, to develop the hypertrophy. And I just do a normal medial flap turbinoplasty. I don't change it at all, you know.
When you shave the swollen septal bodies and the middle turbinate, how long do you keep the sinuses?
Yeah, it's a really good question, David. Yeah, so you cannot leave areas to heal by secondary intention, so mucosal remigration, in airflow. It's terrible. So you've got to cover the areas, and you can't cover it for 5 days. It's not going to work. You know, remucosalization does not occur. I mean, most swell bodies are maybe the tip of my thumbnail, so they're not huge, but you've got to cover it with silicone. We shift something like 15 to 20,000 liters of air back and forth through our nose. It will desiccate and dry out an open wound like that. You have to put silicone on it, and usually 3 weeks. You know, 2 to 3 weeks is sort of the zone where they'll remucosalize nicely. And this is why occlusive dressings are applied on skin. You know, and plastic surgeons use them all the time. If you let the wound dry out and desiccate, epithelial migration on the skin is terrible, and it's even worse in the nose, diabolical in the nose. You know, if you leave a big crusty area, take forever to heal. Yeah.
Yes. I'm sure that body is a bit hungry. Let's just the last question.
You can bring
I think Dr. Harvey will be very happy to answer other questions during the dinner time.
Sorry, just one quick last question. Just want to ask, because of the burnout, how do you clinically assess it? I mean, obviously there's remodeling, and is there an age limit where you would not give anything and just do surgery?
Oh, you mean like this picture up here? Yeah, look, I tell you what, yeah, so some people will come and see me to answer that question, and I look in and they've got this terrible, you know, tissue remodeling on their middle turbinate and septal swell body, and all they say is I'm blocked. And I can't really elicit any allergic drive from them. My eyes don't react, my skin doesn't react, my lungs don't react, I don't have itch, sneeze. Often they'll say, look, with steroid nasal spray doesn't seem to do anything. And look, occasionally, I would say less than 5% of the time, I'll do the surgery first. They still will maintain a positive skin test. So that doesn't change. And so I say, you are sensitized to like dust mite. I said, look, let's do the surgery. And I said, I prepare them though. I say, when we do the surgery, if you become sneezy and itchy, maybe we have to start the allergy afterwards, allergy treatment. Now that does work out for me, but I've been burnt a few times where I've done it and the patient's been really quite symptomatic in this sort of year after surgery. And maybe because their nose was so blocked that they just weren't getting allergen delivery into their nose, you know, so it does happen occasionally, and it also explains this phenomenon, but I would say it's the very small minority in which I do the allergy treatment after the surgery. And you don't want to be doing it afterwards as a surgeon. You're chasing your tail at that point, trying to get the patient to convince them to go along with the treatments. I think as a patient, I'd be like, well, why didn't you talk to me about this before surgery? You know, and a big question patients might ask, but what if I'd taken this before surgery? Might not have I needed the operation? That's a really tricky question to get out of. So you're much better off getting patients started on it and then wrapping it up quickly after surgery if you think they're amazing. you know.
Okay. As we would like to conclude today's symposium, I would like to thank Professor Harvey again.
Thank you.
That's give Professor Harvey the big hand.
Yes.